Hello, I'm Alex Garner. I'm a first-year PhD student at Lancaster University. Thank you for listening to my talk. I'm going to be talking to you about my first project, which focuses on healthcare for care home residents during the COVID-19 pandemic. My project is linked closely with the HDR UK Learning Care Homes project. We know that care homes were badly affected by the COVID-19 pandemic, especially during the first wave, with a significant increase of deaths in adult social care settings compared to previous years. Care homes in the North East had the highest age standardised mortality rates of all the regions in England over the pandemic. At the start of the first wave, the NHS tried to free up the maximum possible hospital beds to ensure they had the capacity to deal with the additional expected COVID-19 patients, leading to difficult decisions for care home staff of how to best get the necessary care for residents. These uncertainties are compounded by rapid policy changes and updates for adult social care in the early stages of the pandemic. We aim to produce a descriptive analysis of how care home residents were treated during the pandemic and demonstrate typical patterns of care that residents received. In order to investigate this, we use linked secondary care, community care and care home data from County Durham and Darlington NHS Foundation Trust. We also have Pillar 1 COVID-19 testing data. These datasets are linked using pseudonymized NHS number so we can identify observations of the same resident across different datasets. The data spans the entirety of these hospital services, covering everyone in the area. It goes from September 2018 to September 2021. The care home data we use is from the Health Call Digital Care Homes app that has gradually rolled out in 123 care homes in the area since 2018. We can use the activation of residents on this system to identify the set of individuals as care home residents and filter these residents out from all of the datasets forming the basis of our cohort. Since there's no central database of residents, we can then use the rest of the datasets to find the characteristics of the individuals we have identified, such as age and sex, and we can use diagnosis codes and appointments to identify any comorbidities a resident may have. Overall, we identify 8,881 individuals in the data as care home residents. Some of their estimated characteristics are shown here. From a broad set of data sets, we can build up a picture of a resident's care over time. We define trajectories as sequences of a patient's healthcare service interactions over time. Each day has a different state, which represents care they received that day. Since there can only be one state per day, we prioritize more significant levels of care, with A&E being the highest and no care being the lowest, which is considered a care home state since they don't receive any external care. The example sequence here would be this person receives no external care for 3 days, then has an emergency attendance at A&E, then spends 3 subsequent days as an inpatient and are discharged on the 3rd day, then are back in the care home on the final day. A sample of 50 of our residents' trajectories can be seen here, starting from when they become a care home resident up until the end of the data. Each resident's entire sequence is long and complex. We use the resident's first registered COVID-19 tests and first positive tests as index events and define subsequences 10 days before and 10 days after those index events. So we investigate 4 sequences overall. 10 days before a resident's first positive test, 10 days after a resident's first positive test, 10 days before a resident's first test, regardless of the result, and 10 days after a resident's first test, also regardless of the result. This gives us information on events leading to COVID-19 testing events and subsequent healthcare response for these care home residents. We remove any residents who died during the sequence period in order to keep all the sequences we are investigating the same length. We can compare sequences by using state sequence analysis techniques. In order to quantify the similarity between a pair of sequences, we use the optimal matching metric. The optimal matching metric assigns the cost of hypothetically transforming one sequence into another. There are 3 possible actions during this transformation: insertion of a state into a sequence, deletion of a state from a sequence, and substitution for one of the states in the sequence into another state. We find the most cost-effective sequence of actions to transform between the two sequences we are calculating, and the cost is the dissimilarity or distance between the two sequences. Once we have a quantified similarity between every pair of sequences under investigation, groups of similar sequences begin to form. We use hierarchical clustering to define these clusters. We can also look for associations between the characteristics of the residents and the types of cluster that they fall into, and see if similar residents receive similar patterns of healthcare. As well as characteristics, we test for associations with the clusters and the outcomes of the test index event. Overall, we test for association between cluster assignment and test result for sequences defined by a resident's first test, 28-day mortality after the index event, wave of the pandemic that the sequence occurred in, whether we have identified the resident to have diabetes, whether we have identified the resident to have dementia, and our calculated Charlson comorbidity coefficient based on their diagnosis codes from their inpatient stays. Here we see the cluster assignments of all four of the sequence definitions under investigation. From 1 to 4, 10 days before a resident's first positive test, 10 days after a resident's first positive test, 10 days before a resident's first test regardless of the result, and 10 days after a resident's first test, also regardless of the result. The number of residents in each cluster is also shown at the top of each panel. The clusters are generally characterized by one dominant state. We see, as expected, especially during the pandemic, that most residents stay at home. These blue clusters indicate residents' inpatient stays during the 10-day periods. When we look at the associations with characteristics, we see that residents who we define to have diabetes appear significantly more often in the clusters representing high levels of care than those who we don't. Residents with dementia are only significantly associated with high levels of care after a testing event. In the before and after first test sequence assignments, numbers 3 and 4 on the figure, we find that residents in the home cluster are more likely to test positive than those defined by the inpatient or community states. Additionally, we can also investigate changes in care due to the test index event. We demonstrate this using Sankey diagrams to visualize the movement of each resident between the clusters. Also here we have the group of residents who died within 10 days that could not be assigned to a cluster. The majority of residents remain in the same cluster. We can see similar sized groups from both before test clusters transitioning into each of the after positive test outcomes. Interestingly, 10-day mortality rate is approximately the same between those who are an inpatient before their test and those who are in the home cluster. You'd expect residents in inpatients to be more unwell. However, this is likely to do with the self-isolation procedures that were in place. So to round up, we've used state sequence analysis to produce care sequence clusters that demonstrate typical healthcare patterns leading to and in response to COVID-19 testing events. We've investigated how these clusters are related to resident characteristics and also the outcomes of the tests. And we've visualized using the Sankey diagrams how care changed in response to the COVID-19 positive test. Thank you all very much for listening to my talk. I hope you found it interesting. Please feel free to contact me with any questions or comments. I hope you all enjoy the rest of the conference, and I'm looking forward to meeting some of you there.